This is going to be a little bit of heresy. If Dave Blaha's in here, if he could remove anything that he can throw at me, that'd be appreciated. What I hope you conclude from my comments here is that we all agree that a pivoting bearing that provides intrinsic stability during functional activities is really the key thing that we're looking for. Again, please take the survey. I do have relevant disclosures. I get royalties from Innovis on the implant that I'm going to be talking about. So we began doing fluoroscopic measurement of knee arthroplasties back in the late 80s. And from the very beginning, what we saw in those designs of the day is that knees basically had poor anterior-posterior stability, the classic paradoxic translations, femur posterior and extension moving anterior in flexion. And as a result, patients of the day manifested poorly controlled knee motion, relatively poor weight-bearing flexion, poor endurance and functional strength, and obviously the implant longevity was not great. So to us, the key element was a lack of functional stability in extension, essentially the loss of the anterior cruciate ligament and normal stabilizers. And so what we sought to do, a little bit different path, was to reproduce natural joint stability in a PCL retaining design. And what we said is, well, if we do a ball-in socket that is conforming in extension in the lateral compartment, that relaxes in deeper flexion, that might be like an ACL substitute. That is, constrains the lateral condyle to be central in extension, becomes lax, and allows the lateral condyle to roll back in flexion. And as a result of that choice, it's going to have a lateral center of rotation in extension, but with a competent medial collateral and a reasonable curve in the medial compartment with the unlocking lateral, we would see a medial pivot in flexion, and so it would essentially be a dual pivot. Now, everybody is familiar. We've seen this graphic, I think, 6 times today. Does anybody have this tattooed? It would not surprise me. No controversy about how the knee moves when you flex deeply or do a variety of the studies that already have been reviewed. But none of the papers so far today have actually looked at this pattern during walking. And there is a body of literature that emanated in the late 2000s, around 2010, that said something different was going on in the healthy, cruciate intact, normal knee during walking. Here's a study from Tom Andriacchi at Stanford, 46 healthy knees, 100% of them measured to have a lateral center of rotation during the stance phase of gait. Kazanik and colleagues at Mass General, so Guan Li and Harry Rubash and company, using biplane fluoroscopy, saw that in those knees, they also had a lateral center of rotation throughout the stance phase of gait. Scott Tashman, while he was at University of Pittsburgh, using biplane, high-speed, 250 frames per second fluoroscopy with tantalum markers implanted into the femur and tibia, so an exquisite measurement in patients who were running, concluded that while the location of the knee rotational axis may be dependent on the specific loading condition, during walking and running, it's positioned primarily on the lateral side of the joint. So there's apparently something different going on in the healthy knee when the knee is ambulatory near full extension, and maybe that's recruitment of the soft tissues. What about this kind of pattern in patients with a total knee arthroplasty? So Mike Meneghini, not too far from here, looked at intraoperative kinematics in a symmetric total knee so that it could move any way that the forces and soft tissues dictated, looked at it with the orthosensor, and what they found is if the patients had an early lateral center of rotation followed by a late medial center of rotation and deeper flexion, that was predictive of superior clinical outcome after arthroplasty. So there's some support. So that's what we designed. Does it work as designed? If we looked at patients fluoroscopically during deep flexion, what we saw was good range of motion, 10 to 14 degrees of tibial internal rotation, and importantly, the medial condyle stayed central on the tibia while the lateral condyle moved posteriorly. when we looked at these same patients walking on a treadmill as designed, there was a fixed center of rotation in that spherical articulation near full extension. So very consistent. So it's a medial pivot in flexion and a lateral pivot in extension. Now, no patient ever comes to your office and says, hey doc, it feels like a medial pivot or a lateral pivot day. What they say is, it feels normal or it doesn't, or I feel weak. And I think this is critical, and all of us agree that controlling the kinematics allows the patients to use their muscles in a normal coordinated fashion, and that they don't adopt a co-contracting strategy. We're going to hear about this more from Dr. Lamontagne later. That these patients contract their muscles normally, so they have better functional strength and endurance. Any clinical benefit to this crazy idea? This is a very carefully matched study, again by Mike Meneghini. 183 of these dual pivot knees versus 183 traditional symmetric CS knees, matched very carefully for age, sex, BMI, ASA scores, etc. And what he found was that at 1 year, using the Modern Knee Society scores and other metrics, that the dual pivot knees reported less walking pain at latest follow-up, despite a greater prevalence of lumbar spine disease. And this is exactly what you would predict based on the differences in the implant design. One was intrinsically stable in extension, the other was not. The difference manifest was during ambulation. More of the dual pivots reported their knee was improved after surgery, and about double the percentage participated in active sports after arthroplasty. So a dual pivot TKA is a thing. It was designed to create more natural AP stability near extension, trying to mimic to approximate an intact ACL that becomes stable in extension, progressively more lax in flexion, with a modestly curved medial compartment that hopefully works with strong medial collateral structures. Patients with this design to date have exhibited improved ambulatory function, higher activity levels, good range of motion, etc. And I think this really reinforces what we do completely agree on, is that having a point of definitive intrinsic stability in the joint allows these patients to perform superior to those who do not. Thank you.